Okay. So, good afternoon. Today we would be discussing about large vessel vasculitis again. Now, this time we would be discussing about Takayasu arteritis. Okay. Takayasu arteritis. So, what is Takayasu arteritis? It is also known as, let's see the other names for the disease, also known as pulseless disease. You would know why later on. Then Martorell's syndrome. Then it affects aorta and its branches. So, we would call it as occlusive thromboaortopathy, aortitis syndrome, aortic arch syndrome, and long segment or typical coarctation of aorta. A typical coarctation of aorta. Yes. So, what are the other names of Takayasu arteritis? It is also known as pulseless disease, Martorell syndrome, occlusive thromboaortopathy, aortitis syndrome, aortic arch syndrome, and long segment or typical coarctation of aorta. So, it is basically a chronic granulomatous vasculitis. So, what will happen in it? There will be stenosis, occlusion, and aneurysm of large elastic arteries, right? So, it is a chronic granulomatous vasculitis. So there would be stenosis, occlusion, and aneurysm of what? Of large elastic arteries. Large elastic arteries means typically aorta and its branches. Aorta and its branches, like pulmonary artery, like coronary arteries. Okay. So what does it affects mainly young Asian women? Like you girls are living in Asia, so young Asian women during their reproductive period. Okay. Now, as the name is Takayasu arteritis, it was first described by the scientist, which was Mikito Takayasu. Mikito Takayasu. Who was Mikito Takayasu? He was professor of ophthalmology at Kanazawa University in Japan. So he was the scientist who first described Takayasu arteritis. So let's see the epidemiology of Takayasu arteritis. Now this disease affects 2.5 per million, 2.5 people per million annually, and the increased incidence is found mainly in Japan. Now, Takayasu arthritis affect more frequently Asian countries. Asian countries, you get to see more frequency. What are the Asian countries like your Japan, Korea, China, India, Thailand, and Singapore? These are the Asian countries. Along with Asian countries, it can also affect Turkey, Israel, Central and South America. So 100 to 200 new cases are reported every year in Japan. Yes, Japan. So what happens in Japan? There is increased incidence of aortic arch involvement. But in India, there is increased incidence of abdominal involvement, right? So in Japanese population, you would get to see symptoms related to aortic arch involvement more. In India, you would get symptoms related to abdominal involvement. Now, obviously, young Asian women in their reproductive age, we discuss. So, females, it affects females more than males, less than 50 years. Females, giant cell arteritis were affecting person more than 50 years. These affect people less than 50 years. Mean age of onset is 30 years, around somewhat 30 years. This was the etiology of Takayasu arteritis. Epidemiology, it affects 2.5% per million annually, with increased incidence noted in Japan. Asian countries are affected more frequently, like your Japan, Korea, China, India, Thailand, Singapore, along with Turkey, Israel, Central and South America. In Japan, 100 to 200 new cases are reported per year with symptoms showing aortic arch involvement. But in India, you would get to see more incidents of abdominal involvement. It affects female more than male. Less than 50 years of female are affected more. Mean age of onset is somewhat around 30 years. That means young Asian females and their reproductive age group. Now let's discuss the etiopathogenesis. Now there are certain genetic susceptibility factors noted in Takayasu arteritis. Susceptibility of HLA-DQB1 and HLA-B MICA, MICA. These are certain genetic susceptibility factors. Now, what happens basically, there are certain autoreactive lymphocytes. So, these autoreactive lymphocytes recognize antigens expressed in the vasa vasorum. Okay? So, autoreactive lymphocytes, they would recognize what they would recognize the antigens, certain antigens expressed in vasa vasorum. What is vasa vasorum? Vasa vasorum are the blood supply of your arteries. Vasa vasorum. So certain antigens would be expressed here and which would be recognized by autoreactive lymphocyte. Then this will get the inflammatory process. This is an inflammatory process. Now certain infections are also suggested in Takayasu arteritis. So what infections? There could be spirochete infection or Mycobacterium tuberculosis infection or streptococcal organisms ka infection. Yes. So there could be resultant circulating antibodies to these infections, which would lead to the inflammatory process. Now, with arteries, it will affect mostly, so it will affect large, medium-sized arteries with predilection for aorta and its branches. In acute lesion, you get to see pan-arteritis with intimal proliferation. Now, let's see this in detail. Firstly, what happens? There will be your natural killer cells, and there will be your T cells, which are the inflammatory cells. So these cells, they would release certain pro-inflammatory cytokines. Yes, NK cells and T cells would give your pro-inflammatory cytokines. Now what they will do, these pro-inflammatory cytokines will further lead to production of MMPs. MMPs are your matrix metalloproteinases. Yes. So matrix metalloproteinases. So what will happen, this MMP would further amplify the inflammatory response. Now, due to this, there would be increased expression of MHC antigens, major histocompatibility complex. So, there would be increased expression of MHC antigens. Now, these MHC antigens, they would stimulate molecule expression on vascular cells. Yes, stimulate molecule expression on vascular cells. Now, what would happen? They would further recruit more mononuclear cells, more. So, this all inflammatory process is happening here. Now, due to all this, what will happen? The vessel is getting damaged, so there would be certain stenotic lesions. Stenosis could happen, or occlusive or aneurysmal lesions of aorta and its branches. Okay. For example, there is renal artery involvement. So there could be renal artery stenosis, mainly suprarenal aorta, which could give rise to hypertension. Renal artery stenosis. Suprarenal aorta is mainly affected. Suprarenal aorta, which would give rise to hypertension. Now, renal artery stenosis occurs in around 24 to 68% of cases of Takayasu arteritis cases, and often it is involved bilaterally. There could be bilateral involvement. Then aortic, there could be involvement of aortic valve. Yes, aortic valve involvement could occur, so there could be aortic insufficiency, or there could be aortic or arterial aneurysm, which could lead to pulmonary hypertension. So this was your pathogenesis. What did we see? That it is basically we discussed some genetic susceptibility to Takayasu arteritis, which was HLA-DQ-B1 and HLA-B mica. Now there is autoreactive lymphocytes which recognize the antigens expressed in vasa vasorum, which lead to the inflammatory process, and there are certain infections which are suggested in Takayasu arteritis. Those are your spirocate, Mycobacterium tuberculosis, or streptococcal organisms, and there could be circulating antibodies to these infective antigens. Now, what happens? Your natural killer cells and T cells, they give your pro-inflammatory cytokines. These pro-inflammatory cytokines lead to production of matrix metalloproteinases, which will further amplify the inflammatory response. Now, due to this, there would be increased MHC antigen. MHC antigen would stimulate your molecular expression on vascular cells. Due to this, there would be recruitment of more mononuclear cells. And in the end, eventually, you are getting certain stenotic, occlusive, or aneurysmal lesions. Now, depending on the artery involved, you will get your clinical features. So, in 24 to 68% of Takayasu arteritis cases, you get renal artery stenosis, mainly suprarenal aorta, which would lead to hypertension. If there is aortic valve involvement, there could be aortic insufficiency or aorta or arterial aneurysm, which could lead to pulmonary hypertension. So let's see clinical features. Okay. So there is acute phase and chronic phase. In acute phase, what could happen? There could be aortic inflammation. So there could be non-specific sign of aortic inflammation, right? So if this is, let's say this is your heart ka four chambers, this is aorta, this is lungs. So what could happen? In acute stage, there is aortic inflammation. You can get non-specific sign of aortic inflammation like fever. Okay. Now, due to aortic inflammation, there would be less blood which would be reaching your muscles, less blood which would be reaching your brains, less blood which would be reaching your eyes, your bones. But there would be more, like there could be plethora in your lungs and here in your heart. So, if the less blood is reaching, like these are your muscles, your vessels, your eyes, your bones, this is your brain. Okay. So aortic inflammation would occur. There could be here tachycardia. You could get tachycardia. You could get hemoptysis due to plethora in the lungs. Now, if the less blood, there is aortic inflammation, if stenotic occlusive lesion, so there would be less blood reaching your muscle. So patient could experience fatigability or weight loss could also be there. If less blood is reaching your vessels, there could be faint absent pulses. There could be stenotic lesions or thrombosis of your vessels also. Or embolization could also be there due to thrombosis. So stenotic lesions or thrombosis, you will get faint, absent pulses. But this would occur over chronic months to years, chronic duration. Now you could get arthralgia, visual disturbances, and dizziness and syncope. Okay. And along with this, your kidney, this is your descending aorta, renal artery, kidney. So there could be renal artery involvement, so there could be hypertension, which renal artery, as we discussed, involved in 24 to 58% of the patient. Hypertension you get in 50% of the patient. Also, it can lead to hypertensive encephalopathy. Now, there could be certain ocular complications in the eyes. So, in the acute stage, there could be sudden blindness. There is a risk of sudden blindness in the acute stage in Takayasu arteritis. In giant cell arteritis also, there was a risk of patient going blind. So we would start IV, IVIG ASAP as soon as we suspect. So there could be sudden blindness in Takayasu arteritis as well in the acute stage due to thrombosis, due to embolization. Now there is ischemic retinopathy. Okay, due to less blood ischemia of the retinal vessels, you would get ischemic retinopathy. Now there are three types in ischemic retinopathy. Firstly, there would be this venous dilation. Then there could be formation of microaneurysm, and there could be AV anastomosis. Okay. venous dilatation or microaneurysm formation, and there could be AV, arteriovenous anastomosis. This is your ischemic retinopathy. Along with it, patient could also have hypertensive retinopathy due to hypertension, hypertensive encephalopathy, hypertension, hypertensive retinopathy. Now, other ocular findings, patient can have cataract or optic atrophy or rubeosis iris, neovascularization at the irises, rubeosis iris or iris atrophy or loss of eye reflexes. These are your ocular complications. Now, as we discussed, Indian population, there is more incidence of abdominal involvement. So, a patient could have inflammatory bowel disease. What all could you get? It could be Crohn's or ulcerative colitis, or it could be non-specific inflammatory colitis, or he could have gastrointestinal bleeding as the first symptom, right? So, these are your abdominal involvement, ocular involvement, renal involvement, your muscles. Then you could get certain cutaneous lesions, which is the main reason why the patient would be in dermatology OPD. Now, cutaneous lesions would be in one-third patient of Takayasu arteritis. Now, in Caucasian population, most common lesion is erythema nodosum, right? Erythema nodosum, most common in Caucasian population. But in Mexico and Japanese population, they could get ulcerative subacute nodular lesions. You will get this in Mexico, Japan. Now, what all could be there? Patient could present with pyoderma gangrenosum-like lesions or papillonecrotic eruption, certain nodular erythematous lesion. Patient could also have facial lupus-like rashes or cutaneous necrotizing vasculitis and paniculitis. Okay. So he could present with pyoderma gangrenosum-like lesions or your papillonecrotic eruptions or nodular erythematous lesions, facial lupus-like rashes, cutaneous necrotizing vasculitis, there could be, and Takayasu arteritis, also paniculitis, inflammation of fat, lobular fat, or septal fat. Now, in pathology, you could see granulomatous features, which would suggest shared pathogenesis. Okay. Also, patient could have stroke or syncope, as we discussed, as the blood flow to the brain is also getting compromised. Patient could have pulmonary hypertension. Now, there could be aortic arch syndrome, right? So, if this is the heart, this is your, if the aortic valve is involved, aortic arch syndrome. What happens in aortic arch syndrome? They could have subclavian bruit, arm claudication, absent or radial pulses. So here, subclavian bruit could be there, and also the blood flow to this periphery is also getting compromised. So there could be arm claudication or absent brachial or radial pulses. That is why this is also known as pulseless disease, right? Absent radial or brachial pulses. Okay, and also you can get to see what could happen. Aortic insufficiency. Due to aortic insufficiency, this left ventricle would get hypertrophied. Yes. So there could be left ventricular hypertrophy. Due to left ventricular hypertrophy, there could be hypertension and there could be congestive heart failure eventually. If the patient presents with this congestive heart failure, that means it has poor prognosis. Okay. Now this was your all the clinical features. Let's just revise a bit. What would happen? So firstly, though, you will get acute. In the acute phase, you would get non-specific symptoms of aortic inflammation. So patient could get fever, then patient could have fatigability, weight loss. He could get tachycardia, hemoptysis. Now, as the disease progresses, you could have stenotic lesions and thrombosis. So they could get faint, absent pulses. Also, arthralgia, visual disturbances, dizziness, and syncope. If renal artery involvement, you could get hypertension in 50% of the patient, which would lead to hypertensive encephalopathy. Now, ocular complications would lead to sudden blindness. In the acute stage, there is risk of blindness. Now, ischemic retinopathy could be there, in which type 1 is venous dilatation, type 2 is microaneurysm, type 3 is AV anastomosis. Patient could also present with hypertensive retinopathy. Other ocular complications are cataract, optic atrophy, rubiosis, iris atrophy, and loss of eye reflexes. Now, in Indian population, we discussed that abdominal involvement is more. So, inflammatory bowel disease could be there, including Crohn's, ulcerative colitis, or non-specific inflammatory colitis. Now, patient can even present with gastrointestinal bleeding directly as the first symptom in Takayasu arteritis. Now, cutaneous lesions would be present in one-third of the patient, in which erythema nodosum is common in Caucasian population. Then ulcerative subacute nodular lesions are common in Mexico, Japan. Then it can also present with pyoderma gangrenosum, papillonecrotic eruptions, nodular erythematous lesions, facial lupus-like rashes, cutaneous necrotizing vasculitis, and paniculitis. Now there could be aortic arch. Also, the patient could present with stroke and syncope. There could be aortic arch syndrome, which would include subclavian bruit, arm claudication, absent radial brachial pulses. Also, the patient could experience aortic insufficiency. Due to aortic insufficiency, there could be left ventricular hypertrophy, which would lead to hypertension, and it could eventually lead to congestive heart failure. If congestive heart failure is present, then it is poor. It has patient has poor prognosis. Okay, this were your clinical features. Now, let's discuss ACR criteria for Takayasu arteritis. It has a sensitivity of around 90.5% and a specificity of around 97.8%. So there are six criteria and you would need more than equal to 3 by 6. Firstly, as we discussed, patient would come. So age less than equal to 40 years or younger at disease onset. Age, the patient would be young patient, right? So age less than equal to 40 years. In giant cell arteritis, we discussed that age is more than 50 years. Here in Takayasu, age is less than 40 years. Now the patient would complain of what? There is aortic insufficiency, the blood is not reaching. So claudication of the extremities could occur. Okay. Also, there could be reduced pulsation of one or both brachial arteries. Also, we could hear a bruit over one or both subclavian arteries or abdominal aorta. So bruit over one or both subclavian artery or abdominal aorta. And also there could be a difference of systolic blood pressure in both the arms, which would be more than equal to 10 mm of Hg between both the arms, right? And then there would be arteriographic narrowing. Okay, there are stenotic lesions, occlusive lesions, thrombotic lesions. So we will get to see arteriographic narrowing or occlusion. Now, where all could you see it? Ecto of the entire aorta or its branches, its primary branches, or it could be in large arteries of upper and lower extremities. Okay, but you have to make sure that this arteriographic narrowing is not due to other causes and it is linked to Takayasu arteritis. So, what all causes not due to arteriosclerosis or fibromuscular dysplasia or others causes? So, this was your ACR criteria. You need more than equal to 3 by 6 for Takayasu arthritis. So firstly, the patient will come in your OPD, you will notice the age. So age would be less than equal to 40 years or younger at disease onset. Then he would tell ki claudication of the extremities. He would complaining. So claudication of the extremities. Then there would be reduced pulsation of one or both brachial arteries. There would be difference in systolic blood pressure of more than 10 mm of Hg between both the arms. You could hear a bruit at one or both subclavian arteries or abdominal aorta, and there would be evidence of arteriographic narrowing or occlusion, either of the entire aorta, its primary branches, or large arteries in the upper and lower extremities, which would be not due to arteriosclerosis, fibromuscular dysplasia, or other causes. So this is your ACR criteria for Takayasu arthritis. Now you would do investigations. So in CBC, you could get leukocytosis, non-specific, which would be, and mild anemia. So these are all the signs of inflammation, no? Mild anemia and leukocytosis. Also due to inflammation, there could be raised ESR, raised CRP, also raised complements. Also there could be hypergammaglobulinemia. Then there could be certain coagulopathies, yes, due to thrombosis, stenosis, occlusion. There could be platelet activation. In ECG, you could get left ventricular hypertrophy. Okay, what is the gold standard? Diagnostic gold standard of Takayasu arthritis is 18 FDG PET scan. FDG is fluorodeoxyglucose, so 18 FDG PET scan is the gold standard for Takayasu arthritis. Now there could be ocular complications, so refer the patient for ophthalmology. And ophthalmological examination could reveal to optic atrophy, retinal hemorrhages, cotton wool spots, cotton wool exudates, venous dilatation, bleeding, and microaneurysm of peripheral retina, vitreous hemorrhage, and wreath-like peripapillary AV anastomosis. Okay, and in fundus fluorescein angiography, you could get a box scarring or segmental retinal blood flow. Hmm. So these are all the investigations. Firstly, to CBC, you would get features of inflammation like leukocytosis, which would be non-specific, and mild anemia. There could be raised ESR, raised CRP, raised complements. There could be hyper. Yes, so on ECG, you could get left ventricular hypertrophy. Gold standard for diagnosis is 18 FDG PET scan, right? Then on ophthalmological examination, patient could have optic atrophy, retinal hemorrhages, cotton wool spots, venous dilatation or bleeding, microaneurysm of peripheral retina, vitreous hemorrhage, wreath-like papillary AV anastomosis. And on fundus fluorescein angiography, one could notice box scarring or segmented retinal blood flow. Now let's moving on to the management of Takayasu arthritis. Firstly, though, you would take measures to control the inflammation and prevent progression of vascular lesions. Control inflammation, prevent progression of vascular lesions. So medical management, glucocorticoids are the first line. Glucocorticoids are the first line. Also, you at the dose of 1 mg per kg per day, oral prednisolone, right? Now you can also use an adjunct like azathioprine. Adjunct like azathioprine could also be used. Others and other drugs you could use cyclosporin, cyclophosphamide, or methotrexate. Also, you could use anti-TNF alpha therapy, and also there is anti-interleukin 6 receptor therapy, right? Which is your tocilizumab, which is used in refractory Takayasu arteritis. Also, now Takayasu arteritis is divided into 6 types based on the angiographic involvement. So this is your aorta, aortic arch, and you know the branches of aortic arch. So in type 1, it involves the branches of the aortic arch. Okay, like this. Branches of the aortic arch is involved in type 1. Now type 2, you have type 2A and type 2B. So this is the aorta, this is the branches. Mm, this is the ascending aorta. So in type 2, it is all ascending aorta plus aorta and branches. Aorta and its branches. And this is involved in 2, like this all ascending aorta, aorta and its branches is involved in type 2A. In type 2B, you will get the involvement of type 2A plus the thoracic descending aorta. So this. So what all we would get ascending aorta, aorta and its branches, and this your descending thoracic aorta. You would get in type 2B. Now in type 3, you have the descending thoracic aorta, abdominal aorta, renal arteries or combination. Okay. So descending thoracic aorta, abdominal aorta, renal arteries or combination of all of these. This, this, and this. Now in type 4, this is your abdominal aorta and your renal arteries and not the thoracic descending aorta. Okay. So abdominal aorta and renal arteries. You will get in type 4. And type 5, you would get everything, entire aorta and its branches. So this. In type 5, you would get entire aorta and its branches. Okay, so let's just go through it again. In type 1, you are just there is just involvement of the branches of the aortic arch. In type 2A, there is involvement of ascending aorta, aorta, and branches of the aortic arch. In type 2B, you will get ascending aorta, aorta, and its branches, plus descending thoracic aorta. In type 3, you would get involvement of descending thoracic aorta, abdominal aortas, and renal arteries or combination. In type 4, there will be involvement of abdominal aorta and renal arteries. And in type 5, you would get entire aorta and its branches. Okay, this was your types of Takayasu arteritis.